Hello, medics. Hope you're doing good. Now, today on what you call gyne and obstetric, or maybe it's just say obstetric and gynecology, okay? We are going to check on mechanism of labor. We know very much that labor is a very intensive and demanding process. And the entire thing from pregnancy up to delivery of a baby, it requires multiple intersectoral collaboration and even individual guided protocols. So from the mother, the conduct, the behaviors, the clinical attending, the prevention, all those, and even lab work. So it takes a lot. It takes not from the consultation, from the examination to approval. So we are going to see after all that time you've attended the antenatal care clinics, the visit, the four visits, okay? And you're done now, you are due, or what we call your term, full term, maybe around 37 to 40 weeks. You're fully actually up to the term. And again, of late, we have people who are post term, okay? Can be due to maybe many other issue being primary gravida or nulliparous, mother who has never given birth. The first delivery can extend. So mechanism of labor. Now we're going to check on mechanism of labor. This is one of the units in obstetrics and gynecology. It's also a unit in reproductive health. It's also a unit which is covered on midwifery, and then can also be done in maternal and newborn health and nursing. So introduction and recap. First, we're going to check on the labor definition of labor. What is labor? People talk about labor. Oh, Brian had a labor yesterday night. People were complaining the mother who had a labor yesterday in the ward passed. So what is this labor at labor pain? Okay, stages of labor. We're going to check on stages of labor. Leopold maneuver that we had already initially checked on when you were handling focus antenatal care. Today we're going to check on leopard maneuver as well. We're going to check on things which are constituting the leopard maneuver. We have leopard maneuver 1, 2, 3, up to 4. So we're going to check out to see the fundal height, the fetal lie, presentation, the attitude, and the position of the baby. Okay. Pelvic diameters, planes and landmarks. We're going to check on the pelvic diameter. Somebody is asking, what is this pelvic? Of course, we have anatomical structure and regional structure of a human body from the head to toes. Being that we know of a skeletal system, talk about skeletal system, talk about the bones, okay? So we have the appendicular skeleton, the axial skeleton, okay? And then we talk about the appendicular, talk about the limbic structure, which of course, the upper limb or the forelimb, we talk about the external structure, and again we talk about the what we call the pectoral girdle, okay? So on the lower limb, we have a region called pelvic. That's the region where the reproductive organs are. So the pelvic diameter, they somehow that pelvic has got a passage. So when you talk about pelvic diameter, we're going to talk about the angle and the distance or the space between the pelvic, okay, from inlet to outlet. So we want to check on the fetal head diameters and the landmarks, mechanism of labor in occipital anterior position, and as well mechanism of labor in occipital posterior position. So mechanism of labor in occipital anterior position and mechanism of labor in occipital posterior position. So occipital anterior position, we're going to check, the occipital part of the fetal head, where it is positioned on the anterior of the pelvic, talk about the occipital anterior. And then when that occipital region is, we're going to check on that. So let me just keep it for up to then when we reach on that part. So let's start. What is labor? Of course, when you talk about labor, you have to include the following. That is regularity, frequent, and even the intensity. So those are hallmark. And don't forget about duration. So a labor, like a regular, frequent uterine contractions of sufficient intensity and duration that results in cervical effacement and dilatation leading to expansion of what we call the POCs or the POCs or the product of conceptions. Okay. So these are the marking. It is not labor unless it is regular. It is not labor until it is frequent. The contraction must be regular, must be frequent, must have a progressive intensity, and the duration must be demarcated. You can have a sharp pain in the lower abdominal region and then it's gone. That is not labor. A pain which is not consistent, a pain which you can take painkiller and it is done, that is not labor. So when you take any analgesic and then it's okay, that's not labor, okay? It's a pain which is not regular, contraction, that's it's not labor. So that mom has not started any labor. What is effacement? Now, during the labor process, many things do happen, and that's what we're going to check. But then effacement is one thing that happens on the lower part of the uterus and the cervix. When we talk about the cervix, it's an organ, actually the internal reproductive organ, okay? So this cervix, it always allows the baby to pass. So it's a channel that connects the baby from the intrauterine space outside the womb or the outside the uterus through the vulva and then outside the body of the mother. Now, during this normalcy, eh, during this normalcy, can you can you please silence the baby? Hello, I hope you're good. So let me proceed. So during this effacement, we always expect the cervix to thin. Mama Malik, mnyamazishe, the cervix to be thinning or to reduce in whatever the thickness. Okay, so effacement is just that thinning of the cervix, because when it thins, it goes and it gets into the lower uterine segment, and therefore it like, have you ever tried like putting or maybe dressing a baby pullover on the head of the baby and you're forcing it to pass? So it's like the cervix is going to birth the uterine, therefore reducing the distance. So it is just the thinning of the cervix, is what we call effacement. Okay, so that distance is reduced. Dilatation, process by which the cervical canal open from 0 to 10 centimeter. When somebody is at 10 centimeter. So that dilatation can also help us to determine whether we have what we call the labor dystocia or obstructed labor, or what we talk about prolonged labor or delayed labor, or those sort of the terms. So labor is called normal if it fulfills the following criteria. Number one, spontaneous in onset and at term. So the labor is normal if the woman is at term. As I said, 37 weeks to 40. Spontaneous in onset. So it kick start. You're just okay, you're just doing your thing, and then suddenly pop, a sharp pain of contraction. Okay. With vertex presentation, of course, still normal under the baby must present with the vertex, that is occiput. So when you go to the ultrasound room, and then you realize that when you do your ultrasound thing on the lower abdominal region, the pelvic lower region, realize that you can see the head of the baby. That head, when it is the one which is presenting, that is vertex presentation. So you're gonna end up realizing which vertex presentation, because we have many vertex presentation. Okay, can be occiput anterior, occiput posterior, and you're going to check on that huku chini on the lower region of this. So without undue prolongation, that is still normal labor. Without having any complication affect the health of the mother of the baby, that is still a normal labor. And abnormal labor, any deviation from the definition of the normal labor. So when I say so, is that abnormal labor is not spontaneous. The baby is not a term. It is not come. The baby is not coming with the vertex presentation. There is no any undue prolongation. There is undue prolongation, and there is also complication. That is abnormal labor. Okay. Now you can see when you're watching on the YouTube, you can see these are the images of cervical effacement and dilatation. You can see that. So true labor pain is characterized by irregular uterine contractions radiating to the back. Frequency of contraction increases gradually. Isn't that like it has increased and then retardated? No, it's supposed to be a persistent increase. Intensity and duration of contraction increase progressively, and then we have a show. Show is just like a brownish discharge, mix of blood and some fluid, thick like, which comes out. Okay, so normally show is because of the rupture of the blood vessel which are actually bathing the cervix. So those blood vessels, when they rupture, they break and then they release blood, which combine with the discharge and fluid around in the cervical. So give us what we call show. Still true labor if the progressive effacement and dilatation of the cervix. So the dilatation, as I told you, is supposed to start from 0 to 10 centimeter. Nurses normally use their finger. I know they mean one finger is 1 centimeter. Okay. So when they do vaginal examination, when the mother is brought inside the labor ward, they do VE, vaginal examination, to determine the cervical dilatation. This is when now you can be told to go and walk around as a mother. Keep on walking, jog yourself as you wait for the cervix to be fully dilated. So this will normally happen. So this, it has to be progressive. Dilatation should not stop at 2 or 3 centimeters. It's supposed to be progressive. Descent of the presenting part. Yes, the descent of the presenting part is also a sign of a true labor. Formation of the bag of four waters. Talk about the four waters, you need to know about the hind waters. Now, the amniotic sac is always level during the consistent regular contraction, uterine contraction. the amniotic fluid divides into two. The water which are in front of the head of the fetus, we call them the forewaters. The waters which are behind or the back of the fetus, call them the hindwaters. So there is always a formation of the back of forewater, and then later on it will rupture. So the ruptures of membrane releases the forewaters completely. So not relieved by analgesic sedation, that is still true labor. So a true labor also should not be relieved by analgesics or sedative. What about the forced labor pain? It's always dull in nature. It is confined to lower abdomen and groin, not associated with any of other features of a true labor pain or discussed, what I've just discussed. Okay, usually relieved when you take sedative or analgesic. So let's see stages of labor. They're divided into four. We have stage one, two, three, four. So we're going to check up to on to each of these stages. Okay. So first stage, sort of the onset of labor up to full cervical dilatation. So and the first stage is now divided into two. You have the latent phase and the active phase. Okay. So the latent phase is the onset of labor up to when the cervix is dilated at 4 centimeters. So 4 centimeter dilation. Okay. The latent phase is prolonged. We call it prolonged latent phase when it exceeds the 20 hours. So sometimes go up to 20 hours when you're waiting it to go up to 4 centimeters at the latent phase. But it exceeds 20 hours. If it exceeds 20 hours in anal liparus, it is prolonged. If it is exceed 14 hours in multiparous, this is a multiparous is a woman with several children. Nulliparous is just the first baby you're giving birth to. Then you have active phase from 4 centimeter to full dilatation. And this active phase has got acceleration phase and what we call the phase of maximum slope. Okay. And then you have the deceleration phase. So acceleration phase, a gradual increase in the rate of dilatation. Then a phase of a maximum slope is defined as the period of active labor when the rate of the cervix dilatation is greater. This is under active phase. But you see both latent phase and active phase is still under first stage of labor. Then deceleration phase, now this speed is now slowing down. So during the terminal portion of the active phase, rate of dilation sometimes slow down. But remember, active phase, we take it from 4 centimeter up to 10 centimeter. That is when it's full. So the average rate of cervical dilatation is 1.2 centimeter per hour. That is for nulliparous, and 1.5 centimeter per hour for multiparous. As I said, nulliparous, women were just giving birth the first baby. Multiparous, they have 1 plus 2, 3, 4 babies. Okay, so it's one and more. So yeah, more than one. So then we go to second stage of labor. This is full dilatation to deliver the fetus. Average duration is 50 minutes, okay, for nulliparous and 20 minutes for multiparous. The second stage is prolonged up to 2 hours in nulliparous patients or 1 hour in parous patients. Now, third stage comes in. This is the interval between the delivery of the fetus to the delivery of placenta. Suppose take around 10 minutes. Okay, if it is 30 minutes, that is now prolonged. Placenta separation occurs along what we call the Nitterback's layer and is the result of continued uterine contraction. Okay, that to that. Okay, so the fourth stage, the first 2 hours after delivery, and what do we do in the first stage? That is always the monitoring of the vital of the mother, monitoring complications such as PPH. Okay, postpartum hemorrhage. That is what I mean. Plus many other things, including psychosis, puerperal psychosis. Okay, so this is a curve which called the Friedman labor curve in nulliparous. You can see it. It has latent phase, active phase, then you have the acceleration phase, maximum slope, and deceleration phase. That is on the active phase of the first stage. Then you have the second stage, then the third stage as it proceeds. Now, let's check on what we call the lie presentation and latitude and position. The relationship of the long axis of fetus to that of the maternal spine and the mother spine is what we call the lie or the presentation or the attitude or the position. So it supposed to be, can be longitudinal, can be transverse, can be oblique. Okay, so longitudinal lie is found in 99% of the labors at term. Then talk about fetal presentation. When talk about fetal presentation, the presenting part in the portion of the body of the fetus that is foremost in the birth canal, like the one which is coming first. So we can have cephalic, longitudinal lie. When the fetal is having longitudinal lie, we normally expect to have cephalic presentation or breech presentation. Cephalic presentation, the head is in front. Breech presentation, the sacrum is in front. Amekuja na makalio, breech presentation. Cephalic, kichwa ndimetangulia. Talk about the transverse lie. Transverse lie can bring in shoulder presentation. Okay. So that is that. So in cephalic presentation, the head is flexed sharply, called vertex or occiput presentation. If head is extended sharply, face presentation. If head is partially flexed, bregma presentation. If head is partially extended, brow presentation. Okay, so all that ones give us to the knowledge of today. So you need also to know the fetal head diameters. And on top about the fetal head diameters, talk about the anterior posterior diameter of the fetal head and the transverse. So you see, it's just like your head. So anterior posterior, that is the from mbele, from front up to backward diameter, and then from sideways. That is what called transverse. And then the average circumference is called the average circumference. Okay. So in the anterior posterior is what we call the suboccipital pragmatic diameter is 9.5 centimeter. So the lower one is submental pragmatic. They do Malaysia. Submental pragmatic. If you forget, just remember all the pragmatic share diameters. So suboccipital pragmatic diameter is 9.5 centimeter. Submental pragmatic is 9.5 centimeter. Then supraoccipital mental diameter is 13.5 centimeter, and occipital frontal 11. So the highest diameter is always supraoccipital mental diameter, that is on the anterior posterior diameter. Then transverse we have biparietal and bitemporal. 9.5 biparietal, bitemporal, 8 centimeter. Okay. Then average circumference 34.5 centimeter. This is an image. It tells you the cephalic presenting parts. You can pause a bit here and learn before you proceed. Meanwhile, we are going to check on this and we are going to proceed with this. So I will break and I take my supper. Prepare for exams up to there.